Can you hear me?
Yes.
Okay, good. All right, everyone, welcome to the Prostate Cafe, where I'm open for any and all questions about prostate cancer. I would like to thank the Dendrion Company, who provides breakfast. They're a really good company with a really interesting product. We like to use it sooner and sooner rather than later, and the results suggest that is a definite benefit. But it's interesting from the standpoint of you have your blood drawn, we call it leukapheresis, and that blood is drawn and then looked at from the perspective of certain molecules that we call APCs, which exist in our blood. And after being taken, it's sent to a lab where it's incubated with other molecules, which are basically molecules which identify immune cells and then supercharge the immune cells to your cancer. And so it's sent back, and then you get an infusion of this. And it's what we call monoclonal antibodies, which is a form of immunotherapy. So it's a heightened immune response. And it's very interesting. And we typically do it 3 times, with each session separated by about 3 to 4 to 5 weeks, something along those lines. And the infusion does take about an hour, but it's not toxic. It's not chemotherapy, which we're not big fans of around here unless it's absolutely necessary. So, with that said, does anyone have any burning questions or concerns? Yes, sir.
So that infusion you just talked about, so that would be done as soon as you're diagnosed, or before? Not before you're diagnosed.
No, it's done later in the process.
Oh, later.
So it's typically done with men who have had evidence of cancer resistance to the standard traditional hormonal therapy. And then the patient becomes a candidate for that. So, I mean, occasionally, upon the diagnosis, a patient may be found to have cancer resistance, but it's usually a lot later along the lines of therapies. Any other questions? Yes, sir.
My wife's brother was just diagnosed 2 days ago with prostate cancer. So he's 76. So what factors, what do you guys think about when you're determining, or a doctor determines whether it should be cut out, surgery or radiation? Is it age? Is it weight? Is it the amount of cancerous cells around the prostate? Is it how far along it is? But what are the factors that determine that?
So he's asking, what are the general factors for a newly diagnosed 76-year-old? Now, regardless of his age, I would first have to ask, do you happen to know what his staging is? Is there a Gleason score assigned to the...
We've asked that score, yeah.
Okay.
I think they did, I think his wife, they did biopsies, and that, this is secondhand, 5 out of 7 came back positive for cancer. Does that make sense?
Sure.
But the Gleason score, yeah, we don't know. We're waiting to hear that.
Okay, so prostate cancer Gleason score, the way it goes is, and I do lots of biopsies, and what I do is you send those biopsy snippets to another doctor called a pathologist, who looks under the microscope and declares how aggressive the cancer is. So what he does is he looks under the microscope and says, okay, this is a cancer I see, and within a group rating of 1 to 5, okay, I'm going to give it, let's say, a 4. And that's the most common cancer he sees under the microscope. And he does this for each and every one of the snippets. The second thing he does is he looks again. He says, okay, but what is the second most common cancer that I see under the microscope, and let's just say from a 1 to 5 to 3. So that becomes a 4 plus 3 equals 7, and does warrant attention. Okay, one may argue that if it's the first Gleason grade is a 3 and the second one's a 3, 3 plus 3 equals 6. If there's not a lot of volume, it could be what we call surveilled. Patient can be followed. Okay, but if it's anything above that, I would strongly encourage not to. And as what you told me, if there's 5 out of 7 biopsy positive, or whatever the number, but if it's 5, I would say I wouldn't just do nothing. I wouldn't do active surveillance because you're putting the person at risk regardless of age. Now, there are other issues at hand. I don't know, does he have other comorbid medical problems, that, someone may influence and say, well, yeah, it's a 6 and a Gleason 6, and there are 5. He has severe heart disease, he has another malignancy in his body or has been treated for. All these other things go into play. But generally speaking, higher volume, even Gleason 6, and certainly above a Gleason 6, 7. At least I don't follow a patient with a Gleason 7 or more, and I get uncomfortable even following a patient who has a Gleason 6 more than 2 snippets. And the reason why we get, at least I get alarmed by it, and I think most oncologists would, is that cancers, when we find them, we know the natural history of cancer. They never get better. They never go away. So that a Gleason 7 doesn't become a 6, become a 5, become a 4. It just doesn't do that. Cancers always become something more aggressive. Okay, we've all had experience now with COVID virus, and we've learned that viruses, while in 2020 was a killer, but thereafter it became a watered down version of it once was, because viruses look to transmit to more people, and they really don't want to kill their hosts. And that's the reason why even, we don't hear much about AIDS anymore, killing so many people, or even Ebola, just because they water themselves down to become more transmissible. Cancers, their goal is to kill. So they always want to become more aggressive. And so if you leave enough volume of even a lower grade tumor in the prostate, it's going to mutate to become something more aggressive. And you have to be very careful about that. And that's the reason why in the cases where we do this active surveillance, also known as watchful waiting, we are careful about it. We do want to do scannings every 6 months to a year, PSAs, sometimes even quarterly, but track the patient closely to be sure that it's not going along the lines of becoming more mutant and becoming more aggressive, and these are problems. I see an awful lot of people these days who even have the lower grade tumors, and by the time they get to me, and again, they're lower grade, I find that they have metastases. Cancers do that. Any grade of cancer, that's what makes them a cancer. They divide faster than normal cells, and they disseminate, they disperse to other areas of the body through the blood or lymphatic channels. So these are issues. Okay, there are other things that you do look at in the pathology specimens. You say, well, each and every one of the snippet, how much percentage of cancer was in the snippet? Was it just 5% of the snippet I sent? Was it 20? The data suggests if it's anything 30% or greater, it's important. Okay, there's enough volume. Other things that you look at in the snippets, is there something we call perineural invasion? And that's important from the standpoint of, so if this is the prostate, and it is shaped like that, and this is the top of the prostate that we call the base. This is the apex of the prostate we call the bottom, and the prostate has a right and a left side to it. But there is a network of nerves, and they go from inside to outside. And if you find cancer on a nerve, then it has a higher probability of getting out of the prostate. Either the tissue is immediately outside or some far away place. So that's another thing that the pathologists will always tell us if they see perineural invasion. And the other things are some other histologic findings. For example, there are these patterns that we call cribiform patterns, which we know even if it's a low grade, if it has any element of cribiform, it can behave more aggressively. And then finally, there's something called intraductal. And if we see intraductal, those are aggressive. They almost behave like lung cancers. So those are important. From the standpoint of treatment, I'm not a big fan of radical prostatectomy. And for many reasons. Not only his age, because I'm sure the urologists, they always will say you're a candidate. But I would just say irrespective of age, I'm not a big fan of it. And I'll talk more about it in this meeting, I'm sure. But let me ask, is there anyone else who has a question? Okay. Then what I'll do is, since he brought up the question, let's just start from the beginning. Okay. So, your PSA has risen, and it's concerning because there's a trend. It's not so much how high it is, it's the rate of the rise going up. Okay, so a PSA of 2.5 is very worrisome if it went from 0.5 to 1.0 to 1.5 to 2. It's concerning because it has a steep rate of the rise, whereas a patient having a PSA of 7 or 8, it goes to 7.5, goes to 8.0. It's not concerning, or just having a high value of PSA is not necessarily concerning, but should still be looked at. So if the patient does have a PSA of 7 or 8, it's got to be evaluated. And if there is any concern, and there are other things that we often do, and one is called a 4K score, and it's a molecular way of determining via urine whether the cancer, or let me say, what's going on in the prostate, there's a high probability of it being cancer. Okay. Right now, I have to say that in the community and in the country, the gold standard for evaluating prostate cancer, or PSA elevation, I should say, is a multi-parametric MRI. And it wasn't that long ago that radiologists looking at them couldn't make heads or tails of it. 10 years ago, they were just scratching their heads and saying, well, it might be something there. And the reason that was the case is because there are many factors at play, but the prostate area moves around a lot. And for those of you who've had MRIs, it's always MRI is a great study for long bones, for the spine, because those areas aren't moving a lot. But the prostate moves all over the place. And so in order for the radiologist to get better at identifying whether someone really has cancer or not, they had to step it up in terms of the magnet strength. And so a good radiology facility these days are going to use something of the order of a 3.0 Tesla magnet is what it's called. And with that, they can get better imaging. And that, I would say, happened about 7 years ago. More recently, they started looking at MRIs at different angles and then merging them all into convergent planes, and they call that multi-parametric MRI. So ideally, multi-parametric MRI with a 3T is the way to go, or a 3 Tesla magnet, and that'll give you good imaging. And whereas they couldn't often in the past tell us heads or tail about prostate cancer, now they go so far as to say, oh, there's a cancer there, and this is what I predict in terms of its clinical significance. Radiologists with MRIs use a grading score from 1 to 5. 5 is the worst, 1 is the best. And so that's what they look at. And today, anyone gets an MRI with the multiparametric phased array and the 3 Tesla magnet will also have a little number at the bottom saying PI-RADS, PI-RADS 2, PI-RADS 3, PI-RADS 4. And as you go up the ladder, there's more significant potential for there being not only a cancer, but an aggressive cancer. And they're these days, they're spot on with that. So that's become really good. They also provide that information to the urologist, or like myself, a uro-oncologist, to fuse that information with the biopsy procedure, so that and I would say that's how most urologists either fuse it or they know where it is based on where the MRI showed it to be, and that's where they at least sample that area of the prostate. Ultrasounds are also really good, but generally speaking, an ultrasound only shows hues of gray, which for the experienced person, it means a lot. The advantage of an ultrasound for reviewing the prostate is that you could take that same ultrasound machine, bring it to the procedure or operative room where you do the biopsies, and whereas you can't bring an MRI into the operating room, or if you did a biopsy with a patient under an MRI, it's going to take you forever. So you don't do it that way, but the ultrasound allows you to be interactive, so you actually see exactly where you're going. Now here, we have a lot of expertise in some very special instruments which are called three-dimensional color flow power Doppler ultrasound. And they're unique instruments, they're really rare. You won't find them in many places in the country or the world, but we actually have three because we base a lot of what we do on that. And that's a test that we do for biopsying. It's a test that we do for initial staging of patients, exactly where is the cancer in the prostate, has it communicated with something on the outskirts. So those are tests which tell us a lot more about the prostate. And then of course, helical CT scans are also important for looking at the entire body and identifying, is there anywhere else where the cancer has gone to? And there are certain things that prostate cancers do, and they like to go to bone. And when they do go to bone, they kind of set up fortress there, and instead of punching and removing the bone like many cancers do, prostate cancer doesn't do that. It actually lays down more bone, and we call that a blastic phenomenon. It's also known as sclerosis of a bone. It becomes highly suspicious for a prostate cancer having spread the bone. The other thing that prostate cancer likes to do is to go off to these little structures that are throughout our body. In fact, there's more of these structures that we call lymph nodes than we have vessels in our body. So lymphatic channels, it's called. Lymph nodes are there in our bodies to remove things that are not supposed to be there. And so they classically remove inflammation and infection. And for example, swollen lymph node under the neck, which accompanies a sore throat, common. But they also recognize cancer as foreign, and there happens to be a lot of lymph nodes in the pelvic area, and they kind of go on up. And those lymph nodes are really commonly affected by prostate cancer, and could be identified with biopsies of lymph nodes, but more recently there are other tests. So once a diagnosis has been made of prostate cancer, then there are other tests called PET scans. Everything else I told you, well, not everything. The ultrasound is interactive and looks at function, at least 3D Doppler does, but the MRI is static, and so it's not a functional image, meaning it can show you something that's abnormal, as can a CAT scan, but it can't show you how it's growing, okay? A PET scan looks for abnormal uptake where malignancies are, and then grades it, and that we call SUV count, and it determines just how aggressive a cancer is based on how rapidly it's taking up the substrate, which is a reagent that you inject before the scan is done. Now, what's become popularized is a PET scan we call PSMA PET scan, and it's a great test because when we scan patients having other cancers, we're not looking for something specific, okay? In other words, got a lung cancer or a breast cancer. Other cancers don't have an imprint that you can actually track. The only thing you can do is inject a glucose molecule and then see where glucose is being uptaken more rapidly, because cancers do uptake glucose more rapidly. But it could be for any reason, a very non-specific reason, that someone's cancer or not cancer is uptaking glucose molecule. Whereas with prostate cancer, it's now looking specifically for this enzyme called prostate-specific membrane antigen, and it's specific to the prostate. And so for that reason, there is a higher probability of picking up lymph nodes. There is a higher probability of picking up lung dispersion, liver spread by prostate cancer, and bone spread. So that's something that, oncologists have in their armamentum now. But I got to tell you, we were involved with PSMA PET scans back to the 2014-15 era, when only the University of Michigan and at UCLA were doing it. And we were doing a nanoparticle test, which was the most sensitive, specific test we ever did for prostate cancer. And so based on that, and we were working with some large universities with that test, also at UCLA, UCSF, and the University of the Netherlands. And the University of Michigan realized we were doing high technology tests, so they picked us to be part of their studies. And so we did have an advantage, because what we were doing is we were doing both nanoparticles and PSMA PET scans. And what I came to realize is PSMA PET scans are good, but they don't show something unless there's a lot of something. So they're not going to pick up, for example, microscopic lymph node disease. And that's where we know it's so common with prostate cancer, is lymphatic microscopic dispersion. So those are some of the issues, or I should say the obstacles with PSMA PET scans. But still, they're as good as we got, and it is specific, whereas other cancers don't have such a specific molecule to pick up. So that's what the diagnosis and staging workup typically entails. And then a decision has to be made. What do you do? Okay, so as I told the gentleman, I'm not a big fan of radical prostatectomy for any age. And the reason I'm not is because I used to do it a long time ago in a giant hospital in New York City with a robotic procedure. And a couple things happen. And number one, and we'll just say if this is a cancer anywhere in the body, okay, I don't know if you could see that, but it might be kind of a circular phenomenon, and that's how cancers usually look on scans, circular, or they may have irregular borders, but what you don't see is what's so common, and that is how the cancer microscopically infiltrates the outskirts. And so we know that's the case, and with most cancers in the body, when you go about to remove this, wherever it may be, you realize that it's going to have those fingers going into the tissues around it. And so you don't just remove this body, you try to remove this and hope that you got it all out. Because again, they're microscopic tentacles, and and that's what you try to do. And the other thing you always try to do is not to lose a lot of blood while you're doing it. And the reason being is that if there's cancer around, if you're working in a cancerous bed, and then you spill your normal blood with the cancer, then they commingle and can be spread throughout the body. And that's real. That's a phenomenon that's very real with cancers, and the reason why you don't remove a lot of cancers. So with a lot of blood spillage, and you can typically accomplish that. Now with prostate, it becomes another issue, and especially since most prostate cancers don't begin here or here. They actually begin here. And so the large majority of prostate cancers begin in the areas that we call the peripheral zone. And if you go back to your pathology, when you did have a biopsy and you look at the pathology, it's going to say where it came from. And I guarantee you it's going to say peripheral zone. And that just means the edge. Okay, and that's an important phenomenon for prostate cancer, especially since the prostate also has no capsule. And I've told you, many of you, go to Google, you'll see it's true. And there's no prostate capsule, and yet most organs in our bodies including the urinary system, do have thick capsules. Your bladder has a very thick capsule. The kidneys have a very thick capsule. Even the testicles do. And then other organs, even the rectum, other areas have capsules. And the reason why that's important is that before the cancer did what I just showed you with the little fingers going out, it had to bore through the capsule. The prostate has no capsule, so it does this easy. It does go in too, but it does that fairly simply. And that's a problem because in most patients who think, and they hear the word it's contained, and that means, yeah, the bulk of the tumor is probably contained. But what about microscopically? It's not so common. Prostate cancer is microscopically contained as well, and then has not involved the lymph nodes. So when a patient opts for a radical prostatectomy, because in their minds they say, well, I've been told this is the most curative thing to do, which the data does not suggest that at all. But that's what is typically told. And remember, there's 100 urologists to me, or maybe more, and that's what they typically do. And they remove prostate surgically. And when they do, however, a couple things happen. Number one, you can't make it a bloodless operation like you try to with every other cancer in the body. You just can't. And the prostate itself is very, very vascular, as are all the organs around it. And that's a problem. Also, because of all the organs around it, okay, you're talking about on the top of it is the bladder, and then it tethers to the front of it. Behind this, which I can't show you, is the rectum tethered to it. You have the urogenital diaphragm down here, and all these critical structures. Meanwhile, all those nerves are going to the bundle, which is called a neurovascular bundle, which sits outside the prostate. And these are all critical structures, and they also bleed easily. But in contrast to other surgeries where I was showing you, cancer is here and it's got its fingers and you try to take out more, you can't take out that more with the prostate, because if you do, then you're going deep into other areas like the bladder and the rectum and the nerves, arteries, and veins, the diaphragm below it. And these are big deals. And by the way, the prostate urethra goes right down the center. That's the conduit from the bladder above it. And then it exits right this way. And there's another group of sphincters here called external sphincters. This ends up going to the penis. Up here, as I mentioned, the bladder joins it. And where it does join it, there's a really big sphincter of the bladder. We call it the bladder neck. And it's a big muscular sphincter that you've been using to control your urine for your entire life. But when a patient has their prostate cancers removed, as I said, there's too many critical structures bounding it. And so when you do remove it, you peel it off the surrounding structures. And just think about this picture. You're taking this like this, and you're coming around like this, and you have to remove that big sphincter. That's a big deal, because I say you've been relying on that big internal sphincter your entire life to control your urine, your urinary flow. And that's got to go with radical prostatectomy. It has to go. No one's ever done it differently. And that's a big deal, because now you have to rely on these small external sphincters for the rest of your life. And they're small. And I know, many men who have their prostates removed who have leakage and incontinence. And that's the vast majority. They may spend some time, a lot of time, trying to rebuild those muscles with pelvic floor muscles and Kegels you may read about. But the fact of the matter is they're really small. And in most men who get prostate cancer aren't, 30 or 20 or, early 40. Most of them are getting up there, whether it's 50 or 60. And so their muscles are getting weaker as every year goes by. And since this is a small muscle, it ends up just failing over time. So even the men who find that they can control some of their urine, they may lose it as time goes on. The other thing that happens is, because the prostate is peeled off, the prostate's a sexual organ, and it's the G-spot in men. It has a lot to do with the creation of the ejaculate, which gets stored above the prostate in these appendages we call the seminal vesicles, and there are reservoirs above the prostate, and they're contain the ejaculate. And then the ejaculatory ducts meet the prostate in an area we call the verumontanum. But because the prostate's removed, and because it's the G-spot, and because it has a lot to do with the orgasm, most men after surgery will have complete erectile dysfunction. And that's a big deal too. Some men do get penile implants and, can help with getting an erection, but they then may find that either they can't get an orgasm or they're just less rewarding because, again, the prostate's been removed. So those are the issues. But, if you just think about this picture, if you remove the prostate, well, you're leaving these fingers behind, and the probability is that there's also these microscopic lymph nodes involved since they sit so closely to the prostate, and so those issues surface. And as time goes on, a man who's had a radical prostatectomy and the complications of incontinence and sexual dysfunction then finds his PSA is going up, and that's the reason why I abandoned radical prostatectomy. I would tell men you're going to get incontinent and have leakage and sexual dysfunction, and they may say, well, if that's the most curative thing to do, I want to do it. But then, as I found, it wasn't, and that PSAs rise, right after the prostate removal or within the first couple of years, and then the same patients need radiation. And then it's, you scratch your head and say, well, why am I getting radiation when I've had both surgery? Why didn't I just get the radiation to begin with? And so anyhow, radiation is another option, and I would argue that in the vast majority of patients, it's more thorough. There's no question about it than surgery for the reasons I just showed you. The other thing is I mentioned the prostate's a bloody operation, and cancers do get spread by that procedure. And you can again go to Dr. Google and find out it's real. Men who had the radical prostatectomy definitely have a higher rate of dissemination to liver, lungs, bones, and the failure patterns are like that. Where if you look into it, you'll see, okay, some of the men fail locally, but a lot of the men fail distantly. And so it's a big deal. But anyhow, with radiation, there are different ways of treating radiation. I've had a lot to do with something called brachytherapy. It's also known as seed implantation, where what you basically do is here's a tumor and you put these tiny little, isotopes around the gland. And sometimes I even put it outside. And that's a great therapy for treating prostate cancer. Interestingly, in the beginning, I had a lot to do with the development of that type of therapy in New York City. And, the biggest series in the world. And at first glance, since I was walking away from surgery of the prostate, which would take 3 hours with a surgical scalpel, I could put the seeds in 30 minutes and never use a scalpel. So that was kind of a home run. And we would leave the sphincter alone, so there's no issues with incontinence, and we can maximally preserve sexual function. Now, again, the prostate's a sexual organ, and sometimes, even though we go out of our way to spare the nerves and leave the prostate alone sexually, sometimes it gets altered. Okay, sexual function can, just by virtue of the prostate being a sexual organ. But the seed implants were great, but after I did that, and a lot of them, I came to realize that the PSAs were also rising, not so much distantly, not in, dissemination, but around the prostate. And that's when I realized that, and that's actually when I focused on why that was, and I came to find what I told you, and that is there's no capsule to the prostate. Cancers begin on the edge, they leak out, and I spent a lot of time in the surgical pathology lab finding that out. And I realized that we would need external beam to treat those areas and to better treat and be more thorough about prostate cancer treatment than the scalpel radical prostatectomy can be, because with that external beam radiation, we can also target these lymph nodes. And that's a big positive. So, I would argue any day that radical prostatectomy is less thorough than a radiation treatment course. It just is. There's an interesting side note to that. And when you look at data, okay, and they'll say, well, wait a minute, the data doesn't support that. Well, the data does support. If you look really hard at the data, you'll see the radiation definitely has an edge with respect to cure over time in radical prostatectomy. But what you don't realize, and maybe don't know, is this fact and that is in those trials, which are called clinical trials, where you randomize men. And so what those trials do is they say, okay, you got cancer, go over there and have that guy surgically remove your prostate. The other person, you got cancer, go over here and have the radiation treatments. And that's the way it goes. And then at the end, they figure out who did what. That's how a clinical trial goes. However, what happens is when you're looking at with treatments and outcomes, what you're doing with prostate cancer is in most cases, is you're trying to find out the treatment of localized prostate cancer, meaning in this region, okay? And with surgery, what happens is sizable number of the men who getting the surgery, they find their disease was outside the prostate. And they say, well, wait a minute, this person doesn't belong in the trial. And he gets excluded from the trial because he doesn't have clinically localized prostate cancer. So you can understand the bias. Whereas the guys going for radiation, well, they don't know. They didn't have the tissues excised and looked at. So they all get it. They all get treated. So they have predictably more bad actors in the radiation treatment arms. And so that's, again, I would argue for that reason that radiation would be superior. Anyhow, that's pretty much the deal. Now, what about patients who have been identified by bone scans, FDG PET scans, PSMA PET scans, that the disease has gone somewhere else? Well, first of all, lymph nodes, I'm going to treat them anyway because, again, we've done enough studies to realize they're involved a lot with prostate cancer. But other areas of the body, such as the liver, the lungs, and especially the bones, prostate cancer has this propensity to go to bones. And so there's a growing body of data that suggests a couple of things. And one is this. In patients who do get their treatment to the prostate actually interacts with areas outside of the pelvis. It interacts with, for example, tumors which are sitting in bones. And it's kind of, as if you sever off the head and it kills things upstream. And that actually goes under a broad catchment that we call in radiation the abscopal effect of radiation. And it basically means that we're only treating here, but boy, it's having a really big impact elsewhere in the body. And so that's important. And as we continue to march along with our own data, and I was working a lot with a doctor who's the chair of the National Cancer Institute in Bethesda, and a long time ago, we identified that in men who had, we call limited metastatic disease. And what it basically means is it's not all over the place. It's in select areas. And in those patients, if we could treat all the areas, it's going to have an even bigger impact than just cutting off the head of the snake. Okay, and that's kind of the philosophy that we use today. And we have a lot of patients who have, over years, 20 years ago, will tell you, yeah, my disease had gone to, identified to be involving all the lymph nodes and bones and things like that. And the cancer is in quiescence for decades. So that's another aspect of prostate cancer treatment that we here involve ourselves with. And it actually goes under the catchment called treatment of oligometastatic disease spread. And it basically just means that in patients who have limited volume cancer outside the prostate, they still should be treated definitively. By doing that, they may have, a complete remission. They may have prolonged complete remission. They may have cure. And this is not only identified now in the prostate, but it's in other sites of the body as well, especially breast cancer, colon cancer, and even lung cancer. So it's being now looked at and adapted for other sites of the body. So those are some of the general guidelines that we use. Now, with patients who have certain features, meaning aggressive prostate cancers or high volume prostate cancers in the prostate, then we say, okay, well, is there anything else we can do? to increase the cure rate. And a long time ago, and actually in the 90s, it was identified by certain clinical trials called EORTC and ARCOG studies that were done in the United States, Europe, and it identified an interesting phenomenon, and that was that for whatever reason, in the patients who got both radiation and hormones, that hormones did something with the radiation and made it work better, okay? And there was a lot of hypotheses as to why that was. And early on, by the way, what happened was hormones were being found to be a phenomenon where if you take away testosterone, being that testosterone's the feeder for prostate cancer, it's the lifeblood for prostate cancer. If you take it away, you starve the tumor. Okay, well, some of those patients who were having that done just happened to get radiation, and that's when they identified, oh, wait a minute, what's happening here? There's a bigger effect, and I often talk about this to you that, not only if you give them both simultaneously, the hormones and the radiation, then 1 + 1 does not equal 2. It equals a bigger number. It equals 4 or 5 or 6. We call that a super additive event or a synergy, meaning one helps the other. So we do commonly use that approach, but not in everyone, in men who we feel need it. And that would be higher grade tumors, more voluminous tumors, and then especially men who have their cancers where we think it's probably somewhere else. And as time is going on, hormones, they're still important in terms of the primary hormonal therapy. Primary hormonal therapy, what it does, and many of you may have had it or been told about it, the primary hormones are injectables. And what those injectables do is they go to the brain and then shut down the molecules that the brain makes to go to the testicles to make testosterone. So it's basically shutting down testosterone. It's kind of like a medical castration. And, many men don't like that because their testosterones get low. And with that, there are side effects, such as hot flashes, fatigue, can be some breast swelling. But, for those of you who we may be recommending it or have gotten it, we feel that, it's a benefit that's above and beyond the side effects. So the side effects are temporary, but the benefit could be, big to begin with, and then potentially long-lasting in terms of cure and even complete remission. So what's happened, though, is over the past several years, and they just keep coming out with more and more, is a second-line agent. And whereas primary hormonal therapy shuts down the central axis from promoting testosterone altogether, newer agents, what they do is they actually don't do that, but what they selectively do is they don't allow the existing testosterone to touch the receptors on the cancer. So it's an inhibitor of that process. And that's worth a lot because it's far more targeted. Now, unfortunately, insurance companies are in on the act, and they say that you can't get those targeted agents unless you're also getting primary hormonal therapy. That's just the way it is. And I have to say that all the data that we started with respect to radiation and hormones had to do with primary hormonal therapy. And we don't know, if we would get a bigger impact by just doing the second line alone. Okay, and that's data that's percolating along right now. But there is a growing body of data which supports using more targeted agents. We just like we don't like chemotherapy around here, because with chemotherapy, it's affecting your whole body. And, it's basically, I think of it almost as a poison that you're infusing through your body, and that poison just happens to kill the cancer cells better than it does the normal cells. That's how chemotherapy works. So now as we get along the line of more targeted therapies with prostate cancer, we're getting away from the whole concept of toxicity because of testosterone reductions. What I've been doing in many patients is who need both, and who insurance companies will pay for both, is to start off with the primary therapy and also give it simultaneously with the second line or the targeted therapies, and then get the patients off of the primary hormonal therapies, which have most of the side effects, and then maintaining just the targeted agents, which don't affect the testosterone. So the testosterone, and there's data now suggesting that it even goes up with these targeted agents. So it's all very, very interesting. As I mentioned, the company who provided your breakfast, Dendron Company, they're also a form of targeted therapy because they're boosting your immune system. And immunotherapies are also becoming really popular for cancer in general and prostate cancer as well. And we know now that certain immunotherapies are going to work better in patients who also happen to have certain genetic mutations. And so the field of oncology is really moving swiftly, and with AI helping, leading the charge, we're finding that mutations can be targeted. So for example, as I just mentioned, the type of therapies where we're using agents not to drop all the testosterone, but rather to not allow it to touch these cancer receptors. That's interesting. Okay, but what about immunotherapies where we're not doing any of that? We're just supercharging the rest of your body to kill the cancers. And, there's a big role for that, but who might benefit even more? And so it's all about mutations. So cancers create mutations in normal cells to make cancer. And so what's happening is, as we find these mutations are happening, are there ways of targeting the mutation? Because if you do, it affects the cancer. So this is really important in oncology medicine now. And, you'll read about some of the really bad tumors like, pancreatic cancer, GI cancers in general, melanomas, where you find selected mutations. And, those types of cancers historically have really bad outcomes. But if the patient happens to be identified to have a mutation, if that mutation has a specific targeted molecule to use against it, then we're seeing these patients live out, 5-6 years, and they'll probably live even longer because that form of therapy is really coming along, and that's where I think we're going to be assisted by AI to figure it all out. And we like to look at genomic profiles, is what they're called, and that's basically where you look at someone and identify if there's any specific mutations. It could be looked at by your tissue of the prostate, but they're getting really good at looking at blood samples. We call those liquid biopsies, where we're not having to even look at the tissue, but we can look at the samples of blood. And right now there's one company that's using looks at almost 400 mutations with your blood, and that's all important because it may mean that there are other things that can be used. Now, we like doing it here, even if we don't use them, but we know that if you have a particular mutation, we might put that in our back pocket and say, okay, we'll see how you're doing. But if the cancer doesn't go away, we'll be able to also use those agents. So that's the thinking. Now, some men also have part of their genetic makeup, not the cancer, but part of their genetic makeup, some mutations, and we call that a kind of a genetic profile, where we look to see that maybe you and your family have increased rates of cancer. So, for example, many men who have prostate cancer, are identified to have relatives, first degree relatives who have prostate cancer, or even uncles and grandparents and things like that. Also, many men who have prostate cancer are identified to have people on the female side of their family who have breast and ovarian cancer. And then there are other relationships like melanoma, colorectal cancer, and pancreatic cancer. So they're all kind of interrelated in a bigger way. So those are tests that we also do. And fortunately, the companies that I've mentioned who look at tissue and or just look at your blood, they've gotten pretty good to identify both. So it used to be two separate samples, but now they look to see, do you have a pre-existing genetic mutation because it's familial, or is it just the cancer that has the mutation? But they're both important now because they both may mean something in terms of treatment and outcome. I think, well, we can talk about some other things. Something else that has become popular in oncology, but especially in prostate cancer, is something we call radioligand therapy. So what is that? Okay, well, it's interesting. And we do them here. In fact, we do them all here. And what happens, for example, if a man has bone metastases from prostate cancer? Well, just as I mentioned, we go out of our way to try to treat all known sites of disease, and if it's the oligometastatic protocol, treating all known sites. But then you have to say, well, are there other areas where there may be something brewing in the bone? So there's a radionuclide, and it's called radium-223. It's also known by a general name, Xofigo. And Xofigo is injected. It takes 60 minutes. It travels throughout the body, and it attacks cancers, whether you know they're there by PET scans or bone scans, or whether you don't know they're there. It's going to go after them all, and that's an interesting form of therapy. There's another one that's been recently looked at, and it's called Pluvicto, and that's another molecule. It's actually lutetium-177, and what it does is it's more soft tissue related. So for men who have spread by prostate cancer to lungs, to liver, or to lymph nodes, then that could be a valuable tool as well. And that's typically given also in 6 divided infusions. And again, they only take about 60 seconds of an infusion. It's fairly simple. So these are all, the forefront of cancer right now. And just as we use the monoclonal antibody, it's called Provenge, is its general name, by the Dendron company. We're also using these radioligand therapies, which is Xofigo has been a popular one here. And it's interesting because I have men who, prior to Xofigo, there was samarium-153 and then Netastron. And I got guys from way back when, and they were getting it then because they had bone metastases, and they're fine now. So, one would argue if they didn't get that. But again, it's an insurance quagmire still. And, insurance companies will only pay for these agents if you meet certain criteria, one of which is the cancer is not responding to other things. And it's called castrate resistance. And that's one of the criteria. Of course, they're also going to want to know, how is your blood samples? In other words, are you strong enough to get it? It doesn't really take much, though, for these agents because they're not that hard. Usually it's a platelet count, which is okay, and a CBC, which is within normal range, pretty much is good to go. But again, because they're so expensive, and so you just have to rely on your insurance company giving the A-OK, because they can cost 6 figures. It's very expensive and more, $300,000 to $400,000 for a whole, 6-month schedule. So anyhow, but my nurses are really savvy here since this is all we do, and so they're always on it in terms of letting you know what we can get for you. And if it's a second-line agent or a more targeted therapy, we're going to be looking into it. And they had their channels within the industry to get it approved, just because we do it so much. Yes, sir.
Once you're finished with the radiation and radiotherapy process, the whole treatment, you're at the end of that. Is there a set of tests or criteria metrics that you use to determine the success, and that if it's necessary to do like these scans and things? Mm-hmm.
Yeah, so he's just asking, what do we do? We've treated you, we've done everything, now what?
Yeah.
Okay, so what we commonly do is we continue to monitor PSA and PAP, blood markers. We continue to continue always to do the 3D Doppler ultrasound, which we do here, knowing that you gotta keep this quiet, okay? And of all places, you got to stop the prostate cancer where it started. Okay, and that's really important. So we'll always look at that, because if I see something on a Doppler ultrasound, something's, rekindling, then I do go to other tests. And I say, okay, we need some other tests to define what's going on here. And that could even predate a PSA elevation. I mean, I pick up these things with, PSAs being undetectable, less than 0.02 or 0.01. I still find things in the prostate that something's happening again. And that's reason for us to say, okay, we got to do some other testing. And that might be light speed helical scans. And, many of you come here, we often do that upon a follow-up to kind of look at your whole body. And then, but that again, that's a static test, meaning we can see what you got. But if we want to find something that's actually happening live, then we go to a PET scan, PSMA PET scan. Again, you can't do it all the time because insurance companies, okay, and they'll cost you a lot of money for all these testings. So we usually know exactly when to do it. Oh yeah, and time is up. Is there any other?
Just one question. Is there any foods and liquids that accelerate this growth, the seed growth?
Saturated fats. It's primarily red beef and pork. And processed and ultra-processed foods. Definitely. All right. Thank you.
You were talking about side effects from, how long do those traditionally last?
It's variable.
'Cause I'm still experiencing it.
Okay. Yeah. And let me say, in younger patients, they have a far more greater inflammatory response. And so they typically have longer side effects from the treatments. We take great pride here in being real precise and lessening those side effects maximally. But, depending on how aggressive we have to be with our treatments, depending on how aggressive we have to do with seed implants and other factors that come in, there are lots of other things, like some men have a part of their tissues protruding into the bladder from the get-go. And, short of going in and resecting it, which we would not recommend, we have to kind of live with that. And we know it's sitting there, and that could bother, because what's happening here, treated here, could then upstream can cause more irritation and inflammation. So it just depends on everybody. But we have, regimens, dietary recommendations for anti-inflammation and supplements and things like that. All right. Thanks for coming. We'll have another one next month.
Morning.